Good afternoon, everyone, and thank you for taking the time to come to today's briefing. I'm Ryan Clary. I'm with the National Viral Hepatitis Roundtable, and we are a national coalition of about 380 organizations around the country. We're working together to end the hepatitis B and hepatitis C epidemics across in the United States. So I encourage you to learn more about us if you're not familiar with us. I also want to thank the American Journal of Managed Care for co-hosting this briefing with us and for putting out the really important special issue. You all should have a copy on your chair or at your table. I really encourage you to take time to read through the articles, some if not all. There's some really, really important information out there about how we can move forward to ending the hepatitis C epidemic here in the United States. So I'm going to talk from the point of view, I'm a public policy advocate, I'm a patient advocate. I have been working on this issue of trying to expand access and, more importantly, to end discriminatory restrictions against people living with hepatitis C for about 2.5 years now with my colleagues around the country, at the national level, state level, and local level. So I want to bring that voice, the community voice, and I want to bring forward the voice of patients who have been denied access. It's a group of people I think have really been minimized and not had a voice in this debate, so I hope to carry some of that forward as well. So just to review some of the statistics that we already heard, but some that haven't been presented, really just to put this into context. So May is Hepatitis Awareness Month, and there have been a lot of articles, a lot of journals, a lot of studies that have come forward. So I just want to drill down to some of the important key takeaway points about hepatitis C, just to understand why there's an urgency behind what we're talking about. So the CDC released the 2014 surveillance report this month, and it showed that hepatitis C is the deadliest infectious disease in the United States. And in fact, it kills more people than 60 reportable infectious diseases combined, including HIV/AIDS. So we're talking over 19,000 deaths a year from a completely preventable and now curable disease. We also found out from CDC back in March when a report was released that hepatitis C is the leading cause of liver cancer in the United States. Liver cancer is one of the few cancers that's on the rise in the United States, and I think we all know it's one of the deadliest cancers in the United States. So we want to cure people from hepatitis C before they are at risk of liver cancer. In April, we heard from the National Academies of Sciences, Engineering, Medicine, formerly known as the Institute of Medicine, probably a brand folks are more familiar with that name, a phase 1 report saying that the academies had looked at the issue and decided that both hepatitis B and hepatitis C could be eliminated in the United States. I think that's a pretty big deal. The fact that we can eliminate on the hepatitis C side a chronic, infectious, often life-threatening disease, we can eliminate in the United States. And there's a movement to do that globally as well. Phase 2 is being worked on, so the academies will be working on some recommendations. But I think it's important to note that the academies also said very significant barriers are in place to reach that goal, one of them expanding access to hepatitis C treatment. We know that the majority of cases, about 75% of hepatitis C cases, are in those born from 1945 through 1965. Everybody born in that birth cohort is encouraged to be tested for hepatitis C. Because of the impact on that birth cohort. And what's important about that, that means that a lot of people have been living with hepatitis C for a very, very long time and are at risk for advanced liver disease, liver cancer. Hepatitis C also disproportionately impacts a lot of communities that are already facing significant health disparities: African Americans, Latinos, Native Americans. We have an alarming new wave of infections. We all are aware of the opioid epidemic. Can't turn on the news these days without hearing another horrible story about how it's impacting the nation. Most of the new cases of hepatitis C are tied directly to that epidemic. So we have an opportunity to actually address new infections by curing people so that they aren't infectious. And as a result, we've seen acute infections doubling over the last 5 years. None of this needs to happen. So you would think that based on all of this, that we would all be working together to figure out how to quickly expand access to treatment and make sure that folks are identified. The more than 50% of people with hepatitis C who don't know their status are tested, linked to care, linked to the cure, and move on with their lives, and we eliminate hepatitis C from the United States. But instead, we're seeing the opposite. We're seeing that most private payers, and we've heard about this, and Medicaid programs have placed what I believe to be discriminatory restrictions to hepatitis C treatment access from pretty much the time that the first new DAA drug was FDA approved. And those restrictions are not limited to these, but some of the most significant ones are based on stage of liver disease. So in a lot of states and in a lot of payers, you have to have advanced liver disease before you can be cured. A lot of restrictions that you really don't see for any other chronic disease based on substance abuse, sobriety requirements, whether current or recent, having to submit urine tests, things that you don't have to do for any other chronic disease that I'm aware of, and limitations based on provider. So in a lot of states or with a lot of payers, you can't be prescribed hepatitis C treatment by your primary care doctor, have to see a specialist. Well, if you think about hepatitis C, in a lot of states, there really aren't a lot of specialists, so it's another way of denying access for people. These restrictions are in direct conflict with expert medical guidelines from the American Association for the Study of Liver Disease and the Infectious Disease Society of America that has created clinical practice treatment guidelines. The restrictions are in direct conflict with these medical expert guidelines. So there's a harm to the patient. I think we've heard a lot about that already. Simply knowing that you're living with a chronic, infectious, often life-threatening disease, think of the anxiety that that patient must live with, and the relief that the patient would feel, regardless of liver stage, regardless of place in his or her life, to know that one big, huge problem is taken care of medically. There's a harm to the provider. Providers are spending so much time on appeals and so much time telling their patient, yes, I'll write a prescription for you, but no, you can't get cured. We have providers here in the room. I see one way back in the Don Fishbein from Washington, D.C., MedStar, who's having to have those conversations with patients. What medical provider wants to have that conversation with their patient? That doesn't fit under do no harm. We've heard about the harm to society, and think of it maybe the opposite way, the gains for society, to have more livers available for transplants, to not have new infections, particularly among young people who are engaged in the opioid epidemic. Numerous examples of how society would benefit if we were to cure everybody with hepatitis C. And in my opinion, really missing a huge opportunity for a massive public health victory, really unlike any others that we've had in a really long time of eliminating this disease from the United States. So in November 2016, last year, Centers for Medicaid and Medicare Services, because was watching what's going on in the states and growing more and more alarmed, sent guidance to the states saying that CMS is concerned that some of these restrictions are actually in conflict with the Section 1927 of the Social Security Act, and told states that to work with CMS to begin expanding access. This was not just a simple letter. This is not something CMS sends often or lightly, in fact, very, very rarely. This is actual guidance to the states, putting states on notice that CMS is alarmed by this. Excuse me. In response, we haven't seen a lot of response, unfortunately, except that the majority of state Medicaid programs have either ignored or actively dismissed the guidance. We have seen letters coming back to advocates from state Medicaids saying, we consider CMS's guidance to be a recommendation. We think we're doing just fine with our restrictions, and we don't intend to act. And in fact, we've seen some states that have acted since the guidance came out, made decisions around prior authorization that are in direct conflict with what CMS sent out. So we still have 40 states with liver damage restrictions. So 80% of the states in the United States still restrict based on liver damage. The worst case scenario is the state of Illinois that restricts to F4. F4 is cirrhosis. You have to have, and I'll let the medical providers talk about what that means. You have to wait until you have cirrhosis in Illinois before you can be cured of hepatitis C, as well as a 1-year documented abstinence requirement. Delaware and Oregon are the other 2 states that restrict to cirrhosis. And then Michigan and Rhode Island are examples of states that have acted since the guidance came out, but are still restricting to F3, F4 with abstinence requirements. This is in direct conflict with the CMS guidance. Some good news, we have a few states that have recently reduced restrictions. We have Connecticut, Massachusetts, California, Washington, D.C., thanks to some great advocacy. Last month, we heard that New York eliminating all restrictions, and just last week, Pennsylvania. announced it was eliminating restrictions. Now, this isn't fee-for-service. This isn't in managed care. That's another piece we have to work on in all of these states. But this is great movement forward, and it's evidence that states actually can move to expand access. I will also note that in these states, this was the result of strong advocacy or a threat of a lawsuit. It's not as if states suddenly woke up one day and decided, oh, it's time for us to expand our access. I also want to note, this is also done in the context of a new era around the cost to states. And we can have a conversation around price and cost. But we know that the price being offered to state Medicaids around the country because of competition, we now have several companies on the market, is nothing close to the $1,000 pill or the $84,000 or the $90,000 that's constantly talked about. We're talking about a third of that. So the conversation that we have to have around Medicaid access has to be done in the context of what the price actually is to state Medicaid. So we absolutely have to stop talking about the $1,000 pill, the $84,000, because it's not accurate, it's not the facts, and it's harmful to patients to hear, to have that conversation when it's not based on accurate information. So I believe it's time for action. Lucinda Porter, who's a great hepatitis C advocate, wrote a piece this month saying Hepatitis Awareness Month without action doesn't mean anything, and I agree with her. I come from the HIV advocacy world. It is really time for action around this. We believe that CMS must work to implement the guidance and to put states on notice that if states aren't moving or showing a good faith towards moving, that there's action to be taken. For those, and I'm grateful to all the staff from congressional offices who took the time to be here today, I guarantee you that with very few rare exceptions, there is somebody in your state or district who has been denied access to hepatitis C treatment, and I believe the members of Congress should be communicating with state Medicaid program to ensure that there's expanded coverage and access to treatment. On the provider-patient advocacy side, everybody needs to continue weighing in at the state level and communicating with CMS, in my opinion. I also don't want to lose the opportunity to talk about the importance of screening and linkage to care, though, because we've been talking a lot about cure. For the more than 50% of people living with hepatitis C who don't know they have hepatitis C, the cure means nothing to them. And the benefits we'll see for the patient, the provider, and society won't happen unless we really work hard to identify those folks. And that requires resources. So advocates have called for a $62.8 million appropriation for Division of Viral Hepatitis at CDC this year in this current in the FY 2017 appropriations bill. It is a modest increase that would really pay off down the line. The U.S. Preventive Services Task Force recently, about a couple years ago, updated its screening guidelines to call for one-time testing of baby boomers and ongoing testing of those at risk, but we're not seeing that implemented throughout the country, through all payers and through all healthcare systems, and we need to make sure we do that. The issue of reimbursement for hepatitis C testing in emergency rooms is huge. The Medicare National Determination that provides coverage and reimbursement for hepatitis C testing restricts the setting and does not include emergency room. And we know that the emergency room is showing to be a place where a lot of people are being identified, 10 to 12% prevalence in a lot of places, but the lack of reimbursement is really a barrier and something we need to work on. And as we work, and rightfully so, on funding and policies and legislation to address the horrible opioid and overdose epidemic in the United States, given the connection with hepatitis C and with HIV, and honestly with hepatitis B as well, we need to make sure that those disease-specific issues are included in those efforts. And so I would like to close my presentation, and really all of our presentations, I'm glad that you could see a little bit, by showing the patient point of view. This is an article that came out about 3 weeks ago in the Cronkite News in Arizona. This is actually a patient. I have been working with his medical provider for about 2 months now, trying to work on treatment access. His name is Jose Robles. He lives in Flagstaff, Arizona. He is 18 years old. He was infected with hepatitis C at birth. He is at F0. He doesn't have advanced liver disease. He's 18 years old. But because he doesn't have advanced liver disease and he's on Medicaid, he can't get cured of hepatitis C. Now, why is this important to him? Because he would like to join the Marines. He would like to follow in his brother's footsteps and join the Marines, and when he tried to enroll, he was told by the Marines that he can't enlist until he's cured of hepatitis C. So we can work on that piece on the policy and why is that a restriction. But until then, he's in limbo. He would like to serve in the Marines. He would like to move on with his life. He'd like to serve his country. And because of the restrictions to hepatitis C treatment, he can't do any of that. And he's waiting on appeals. His medical provider has spent countless hours when she should be treating and curing other people and helping people living with a variety of diseases because she's spending so much time on him. He's just one example, but when we talk about value, please think about the value of being cured for this young man, not because he's worried about being sick or dying soon, but because he's been denied the opportunity to enlist in the Marines, to move on with his life because of these restrictions that, in my opinion, are discriminatory and unfair.